I'd like to introduce Dr. Anthony Sanders, who can tell you a little bit more about himself. And he's going to tell us about what that physical, anatomical, what happens to the body, and why do you look so funny when you're pregnant? Okay, maybe not funny, but why do you look different while you're pregnant? Thank you.
My name is Anthony Sanders. I'm an OBGYN. I've been practicing on the east side at Community East Hospital since 2009. I went to the illustrious Fisk University down in Nashville, Tennessee. And then I matriculated from there into Meharry Medical College, right across the street. And then I came up here to Indianapolis to go to IU School of Medicine for my OBGYN residency. Straight out of there, went into working with Community East Hospital and the Community Health Network since, again, 2009. I will be talking about the process of pregnancy. I'm a visual learner. I'm a visual speaker. Let's see if we can hit. So our goals today are to talk about some normal and abnormal changes during the pregnancy. Some warning signs that can be helpful in identifying what a patient might be, or your partner might be going through during pregnancy, and things to say, hey, we should call somebody or we should go in and get this checked out. Some complications of delivery, and then some concerns for postpartum or after the baby is born. So we've been talking a little bit already about statistics and information about what regards in regards to maternal mortality. And once again, as Dr. Funches mentioned, maternal mortality is any death that occurs during a pregnancy, during the delivery, or within 42 days of the pregnancy being over, and again, even up to a year. As pointed out, the United States has the worst maternal mortality rate in the world in regards to developed countries. And so that's obviously terrible. We're not doing good. We have too much money in this country to be dealing with the maternal mortality rate that we have to deal with. So when it comes to Black folks, Black births account for only about 15% of all the deliveries, all the births that happen in the United States. But 34% of the time, 34% of maternal deaths are Black. So we account for only 15% of the births in general, but we also account for 34% of the maternal deaths. And then just put it in a form. When it comes to Black folks, you can see things are getting worse. This is the data from up to 2020. Things are getting worse across the board for all ethnicities. But this is we've always been the worst. It's a responsive board. Okay. All right. Let me stay here. We've always had a higher rate, as Dr. Miller was pointing out, 3 to 4 times higher than our white counterparts. But then it just keeps getting worse and worse. And you can tell that our worsening rate is higher than everybody else too. So we've got incremental worsening for our white counterparts, more severe for our Hispanic counterparts. And look at us. Let's see what happens. Look at that. So just some basic female anatomy. Some folks think they know, but they really don't. So the uterus, this is where the baby is developed. So if a woman will release an egg, we can be adults, right? Mm-hmm. All right. Y'all have sex. During fertilization, sperm makes its way up to this. The egg meets the sperm in the ampulla region. That's the middle of the fallopian tube. Then once fertilization occurs, the process of it turning into a human being begins. It takes about 2 weeks to get from this area to this area where it implants, where the fertilized embryo will implant. And then it takes around 40 weeks from the last menstrual period to develop from an embryo to a survivable human being. Once that process is complete, the baby got to come out. It's either got to be pushed out or taken out. Most of the time, 70 to 75% of the time, a vaginal delivery occurs. But then you have that 25 to 30% in some places across the country, up to 35, 40% of the time we end up needing a C-section for a lot of different reasons that we'll get into later on. So again, woman ovulates, releases an egg during sexual intercourse, and then releases their seed, and they meet right here. And it travels over a 2-week time frame to here. 40 weeks later, or around there, y'all have a different conversation. Some of it is, how did we get here? So I'm going to talk about 3 primary systems. There's obviously many more systems in our body than just 3. All of the systems of the body go through changes during pregnancy. But these are the 3 where we see a lot of complications. The cardiovascular system being your heart and lungs, well, your heart and blood vessels, the respiratory system being your lungs, and of course the urinary system in regards to your kidneys and your bladder. So the cardiovascular system. So first thing, the blood volume almost doubles. So wherever your blood volume is right now, almost twice as much blood volume develops, even and not just throughout the pregnancy, early on. It takes a lot to go once that embryo implants. It takes really a lot of energy, a lot of focus from the body to turn that into a functional human being. A lot of energy. And it wears on the body, and if the body doesn't adapt to that, neither the body nor the pregnancy will survive. So the body has to adjust, and so one of the ways it does that is by increasing the blood volume. All of our systems need oxygen in order to function. And so one of the things that also happens is an increase in the blood cells, the red blood cells. Those are our primary oxygen sources. And again, a good amount of energy goes to turning that embryo into a functional human being. And in order to do so, a lot of blood flow has to go to it. And so with everything in the uterus that is going on, it takes a lot of blood volume and a lot of blood cells. So it has to, the body has to increase the production. The heart gets a little bit larger naturally because it has to work harder. If you're gonna pump out more than, almost double, the amount of blood, and circulate that through the body, it's gotta work harder. Like any other muscle. If you work your bicep more, it's gonna develop more. If you work your quads and your glutes more, they're gonna develop more. Get stronger, get bigger. So there's a natural increase in the size of the heart. Again, so that it can work harder and be more efficient in order to develop this human being. The blood pressure. Most of the time, at the beginning of a pregnancy, the blood pressure is going to stay around the same. Maybe even take a little bit of a drop, just because of the way the body is responding to the new pregnancy. In the middle of the pregnancy, so the pregnancy is typically broken down in trimesters. First trimester, when it first happens. Second trimester goes from about up to 14 weeks is the first trimester. 14 weeks to 28 weeks is the second trimester, and 28 weeks all the way up to delivery is considered the third trimester. There's a fourth trimester, used kind of loosely, but it's an important time frame after the baby is born, in those first 12 to 14 weeks after the baby is born. But in order to, for a lot of different reasons, and the way the body is, again, adjusting to the pregnancy, blood vessels dilate and the blood pressure tends to drop or stay around the same. Then in the third trimester, at the 28 to 32 week mark, around that time frame is when the blood pressure starts to go up again. Again, for a lot of different reasons. In part, it's due to, well, the body's about to go through a significant amount of change and significant amount of stress, and the blood pressure has to respond to that. So it goes up. And we'll talk about some complications of the blood pressure being elevated. As mentioned, it's one of the number one reasons why we're seeing such a high maternal mortality here in this country. Pregnant women get tired really easy. Metabolism is skyrocketed. It's never going to be higher than it is at that time. And it takes, again, a lot of energy in order to develop a human being. So they get tired real easily. They cannot work as hard. So the little things that they would normally do, let's say a person typically lives on the third floor of their apartment building, they run up and down those steps quickly with bags of groceries. Now barehanded, they can barely get up the first flight even in that first trimester. They just can't tolerate the exercise or the stress on the heart as much. Just get fatigued. It's not problematic all the time. It's just a normal part of being pregnant. And then again, swelling, common things. These are all normal things that happen during a pregnancy. Swelling in the legs, swelling in the feet. Swelling actually occurs in just about every part of the body. But it's what we call dependent edema, when it's below the waist. And that's because most of us are standing a lot, we've been sitting a lot, and the blood flow is different, the circulation is different during pregnancy. So it doesn't always get a chance, the blood volume doesn't always get a chance to leave the lower part of the body as easily. And so you see, at some point in the pregnancy, a pregnant person is going to complain about swollen feet. That is a guarantee. But is it a problem or not, kind of depends on what the circumstances are. So the respiratory system, breathing system, moving oxygen in and out. Early on, of course, the pregnancy is small, the uterus is still small, still sitting in the pelvis, below the belly, well below the belly button, still around the level of the bladder. But their lung capacity starts to change. How much can the lungs contain? How much air can they breathe in? That starts to change. We talked about the increase in blood volume. We talked about the increase in blood vessels and how everything has to move. It takes you still got to move oxygen in. You still got to move carbon dioxide out. And as the pregnancy develops, as the uterus starts to get higher, it becomes more difficult to take a deep breath. If everyone takes a deep breath real quick, take one. In through your nose, out through your mouth. Do that again. In through your nose, out through your mouth. In order to do that, in order to fill your lungs all the way up, your diaphragm actually moves down. If you're taking a deep breath incorrectly, you take that deep breath with your chest. If you take it correctly, the diaphragm pulls downward and lets all the oxygen in that you can possibly take. Well, now try to do that with something pushing up against your diaphragm. Almost impossible to fill up your capacity as much as you normally can. So that's where that pressure on the diaphragm is as the pregnancy goes up. The waist goes from the bottom of the rib cage to the top of the pelvic bone. And most folks, by the time they're pregnant, ain't getting much taller. So the pregnancy continues to grow, and then you start seeing the pregnancy stop growing up and start growing out. But there's no more space in the torso. And all that pressure on the pelvis. So again, they're already gonna get tired easily. We talked about that. Now, when our brains say that we're tired, one of the first things we start doing is breathing faster, breathing more deeply to try to get more oxygen in to our hearts, because our brains say we need to breathe more. But we can't do that as much during pregnancy. And so it leads sometimes to hyperventilation. That's breathing more rapidly. And it ends up not being as efficient because you're breathing rapidly, but you're not taking deep breaths. So you're not getting as much oxygen in, and you're not clearing your system of the carbon dioxide as best as you possibly can. But on average, the breathing rate will stay about the same. So most people breathe maybe 10 to 14 times per minute. It gets up a little bit, but on average, most women who are pregnant will breathe about the same rate as when they're not pregnant. But that problem is they're still not breathing efficiently because they need more. Weight gain is a normal thing to happen during pregnancy. And most of the time, people are going to be heavier during their pregnancy than they ever are outside their pregnancy. And so when our bodies gain weight, it takes more to move it around, more energy to move it around, more effort to move it around. I mean, if anybody ever goes to the gym or works out and just picks up some even lightweight, the heart rate goes up, start breathing a little faster because you're carrying more weight around than what your body is normally used to. But if you are at the gym, for example, and you are working out, and you try to breathe at the same rate as when you're resting, you will pass out. It's just not going to work. You're not going to get enough oxygen in. You're not going to clear the carbon dioxide fast enough. Again, a high amount of energy is necessary. A high amount of blood flow is necessary through the uterus in order to turn that embryo into a functional human being. So the oxygen need is higher. But all these other normal issues come up and make it more difficult to function. So the urinary system, the kidneys and the bladder, something's got to happen to all that extra blood that's being developed. It's got to be cleared out. I see two people that might have been pregnant before in this room. I don't know how many people had children. How many people were around the pregnant person when they were? So all y'all know that frequent bathroom breaks are common during pregnancy. And it goes back to what we were talking about, the higher blood volume. That the system, the urinary system has to become a lot more efficient. The blood volume again goes up to the uterus, but then also to the kidneys. So more flow going through the kidneys are going to be much more efficient. It's got to come out. The bladder capacity does not go up. In fact, y'all know, feels like it gets a little less. For those of us who have never been pregnant, we praise God. But we also know that if we put a bowling ball on our bladder, we'd be in some trouble. In some trouble. So the system has to work more efficiently because of all the fluid that's in the system. You get a higher flow going through the kidneys. But water retention is, again, a normal part of being pregnant. The system shifts fluid a lot more easily outside of the blood vessels to kind of retain a little bit. So the body is gets under the impression that it does not have enough fluid in it, so it retains a lot of water. That's part of the reason why swelling occurs in just about every system. And so one way, we'll talk about this a little bit after, towards the end of the presentation, but one way to kind of trick the body into letting go of some of that is to increase the water intake, which sounds ironic. But the more water you intake, the less retention you actually develop. Any questions so far? This is an interactive situation. Yes, sir.
Going back to the cardiovascular piece, a question about two questions. One is, does the ramp up, if you will, of the heart, the blood and increase and all that, does that happen within the 2 weeks? Prior to like what time frame are we talking for that ramp up to occur? Number one. And my second question is probably not as relevant, but I'm just curious if a person had, say, sickle cell, and this happened. I've heard that the child could be born without it. I'm trying to understand the commingling of blood when one is normal and the other is sickle. That may not be relevant. I'm just curious.
It's increasingly relevant because we are Black.
Right.
and then we will have a higher rate of sickle cell disease than any other ethnicity in this country and in the world. The answer to the first question is around the time of implantation. So the body barely really knows that anything has happened in that first 2 weeks, because yes, the fertilization has occurred, but if a mistake develops, if a mistake happens during the development of the embryo, the body may never even really know, the person may never even really know that they were pregnant. So by that I mean a genetic mistake occurs and the pregnancy no longer is developing. It turns into a miscarriage. And it may happen that the miscarriage completes itself around the time that that person's period was supposed to occur. So they never even knew they were pregnant. And so most of the changes begin around the time that implantation occurs. So after that 2 weeks is up, around the time that a pregnancy test might turn positive. Yeah. And then to answer the second question, yes, the blood of the pregnancy commingles with the maternal blood. However, it doesn't really have much of an impact on the pregnancy itself. Definitely does, but the blood of the baby does not necessarily have much of an impact, because so sickle cell disease is a genetic problem. So your parents have to have the gene, both of them have to carry the gene in order to pass that on, even to have a chance of passing it on. Let me put it that way. So if mom is a sickle cell carrier and dad is not, then it's impossible for the baby to have sickle cell disease. Now the baby might carry that gene and pass that on to their future children, but they can't have the disease. Mom and dad both have to have the disease in order for the baby to develop sickle cell disease. What happens a lot of times with sickle cell disease carriers, or actually having the disease, they will have a lot higher complication rate with high blood pressure, with development of blood clots, with pain crises that they have. Again, the pregnancy itself increases the risk of all that a lot in regards to what we were talking about. Because their blood cells, so sickle cell disease damages the blood cells and decreases their oxygen capacity. They can't carry the oxygen like they're supposed to, so they'll get tired a lot more easily. And they have a higher risk of urinary tract infections because those sickled cells damage the kidneys and damage the bladder, and increase their risk for having infections there. So being pregnant has an impact on sickle cell disease, but the blood from the pregnancy does not. Does that make sense?
I mean, I'm sure it's a whole lot more complicated than that.
It's a whole lot more complicated than that.
You asked the basic question, and
Yeah.
I think it does, considering that sickle cell is an issue that minority communities have. I do think it's relevant to that part of the conversation. I'm just curious biologically, but we don't have to go there.
Yeah. It's kind of very in depth. Any other questions? All right. So some warning signs. So the cardiovascular system is responsible for managing our blood pressure. It's responsible for managing bleeding disorders. And so we want to look at what are the potential complications, especially considering that our number one cause of death for our maternal patients is hemorrhage. And very close to being number one. Number two is high blood pressure issues, at least here in Indianapolis. So some of the warning signs that we want to look for, okay, when do I need to at least talk to somebody? At the very least talk to somebody, or even come in and get evaluated. So headaches. Headaches are very common during pregnancy. Not all of them are because of a problem, like a problem that can cause mortality. Some of it is pregnant people don't sleep very well. Some of it is their appetite is not as up to date, or has not been satiated as well. So pregnant women are hungry. I'm gonna advise the men in the room to shh. But if they're not eating a balanced diet, that can impact a headache. Dehydration can impact and cause a headache, or simply you can cause a headache for it because you saying making comments. But headaches that are non-responsive to medications. So always, number one thing is to always talk to the healthcare provider about what is safe to take and what is not safe to take during pregnancy. If the doctor has said this is safe to take for your headache, take it. If it does not work, call them. Because I'll give you an example of Tylenol. Tylenol is getting a little bit of a bad rap with what in relation to taking it during pregnancy these days. But for all intents and purposes, Tylenol is the really only over-the-counter pain medication that we know will not cause birth defects or genetic abnormalities or complications during the actual pregnancy. If a person takes Tylenol, it should work the vast majority of the time. And if it does not, then we may have an issue that needs to be addressed with the healthcare provider. Shortness of breath. We talked about how fatigue sets in very early in pregnancy, easily fatigued very early during pregnancy. It does not get better towards the end of the pregnancy. For a lot of them, it gets worse towards the end of the pregnancy. And when you're fatigued, oftentimes you'll breathe faster. You'll feel short of breath. You feel like you can't catch your breath. However, if it seems abnormal, and this is really the case with all this stuff, because a lot of this could be considered and is oftentimes, unfortunately, written off as normal parts of being pregnant. But if it feels abnormal, talk to somebody about it. There's never a reason not to talk to somebody about it. I'm not talking about your Facebook friends or your TikTok advisors. I'm talking about somebody who's been trained to know what they are talking about. They went to school, they got a degree, and they know what they're talking about. But shortness of breath, outside of what you would consider normal for yourself, chest pain. It should never hurt to breathe. Your chest should never just hurt while you're just sitting. Breast development during pregnancy is, again, normal because the body expects the person who's pregnant to breastfeed, and that's going to make the breast hurt. But the actual chest inside should not hurt. It should not hurt when you feel your heart beat. It should not hurt when you try to take a deep breath. These are not normal signs. Excessive swelling. We talked about swelling being normal part of being pregnancy because the cardiovascular system and the way it is working. But when the feet are swollen, you'll see a slight increase on the left side versus the right side, but it shouldn't be drastic. You shouldn't look at one leg and think it's a log and the other one think it's a stick. It should be around the same size. If one side is larger than the other, then you start having to worry about what Dr. Miller was talking about with Serena Williams and the deep vein thrombosis or blood clots in the legs. And those are dangerous because they can travel to the lungs, they can travel to the heart, they can travel to the brain. Blood clots inside your blood vessels are always in there. So we're looking at the swelling excessively on one side or the other. Another thing, swelling, because it's so common, it has not been used in the diagnosis of something called preeclampsia. We don't use it as part of that diagnosis tree anymore. However, if last week you're 175 pounds and this week you're 225 pounds and you're swollen, that's a problem. And that's something that you really want to pay attention to. Excessive swelling, and again, especially when it's unequal. Visual changes. When you're dehydrated, you're going to see a floater every now and then. When you're tired, you're going to see a floater every now and then. But if you've been well hydrated, you just ate, you woke up, and you're seeing spots, you're seeing floaters, that's a problem. These are all signs that we're dealing with a potential complication. Decreased fetal movement. So everybody expects a wild child on the inside, and that is appropriate. But babies take naps on the inside just as much as they take naps on the outside. However, they should be moving at a certain amount, and the amount can vary. I should say it this way: the amount that is advised to be normal is kind of provider dependent. Some people think 6 is okay; other people think that 10 is better. But if you don't feel like your baby is moving enough, then you need to talk to somebody about that too. And maybe the talk says that everything is fine, and that's all right. But if you're not satisfied with that, hospitals are 24/7. And you can go in at any time and get checked out and make sure that the baby is okay. Excessive bleeding. Bleeding during pregnancy, especially after intercourse or during an exam or just at certain points during the pregnancy, could be considered normal, but it should never be heavy. Light spotting, we'll be accepting as normal or common, but if it has not happened before, then suddenly you started bleeding, ask a question. And the doctor or the nurse practitioner or whomever you're talking to may say, that's okay. You kind of expect that for where you are in your pregnancy. But if it ever is heavy, like they're on their cycle again, if you're soaking a pad, if you wake up and it looks like a murder scene, these are all problems. It's never okay. You get up, go to the hospital immediately. Call an ambulance if you don't feel like you can. If you don't feel like someone can take you, then you call an ambulance and let them do that. And then severe abdominal pain. Labor is the worst thing I can imagine on anybody. It looks very awful. It is typically the most severe pain that any person is going to feel throughout their lives. I've had some of my patients tell me that they'd rather go through labor than have a kidney stone. But if that's what you're comparing things to, then you've got to, that gives you a level of what severity of pain we're talking about. However, labor comes with timeable pain. So it comes, then it goes away. And it comes again, then it goes away. And it comes again, and it goes away, then it's baby. Severe abdominal pain that is there constantly is a problem. If you start having pain and it does not go away, or if you notice your partner's having pain and it does not go away, oh, my belly hurts, but it's starting to get better. And sometimes they don't, I've seen, they can't talk, let's be honest. If it's real labor, there's a quiet, you better be quiet. Sometimes it's screaming. And just be there and be supportive. Rub their back or don't. They might not like that at the time. You might hear words that you hadn't heard before. You might get called something you never been called before. But as that eases up, you can tell the person starts to relax a little bit more. They're not cussing you out anymore. Your mom's not what she called her anymore. You ain't what she called you anymore. Things get better. Then it's bad again, then it's better again. But severe pain where you can't talk, can't breathe, can't move, and it's just, there's no letting up. That's a problem. It's a complication. Yes, sir.
So if a person had issues with, say, headaches before the pregnancy, and Tylenol did not work then, then how might a prognosis or prescription or something be dealt with during pregnancy if that very same issue cropped up? If Tylenol don't work before, then what would be, the option? That's the first question. I always have two.
That's all right.
The second one is, we probably can't talk about this, but Dr. Fudge, I'd love to get further into this conversation about how does a person considering their insurance play into their response to these warning signs. If, for instance, I feel a certain way today, but I don't know if I want to, let me deal with this for a minute and see. I just wonder if that's ever been a conversation that you have heard where people allow things to go on because they're concerned about the plan that they have.
Yeah, absolutely.
Or whether or not that's covered.
So the answer to the first question is hopefully at the beginning of the pregnancy, the conversation about I have a history of headaches has been had with the doctor. Migraines, for example, very common in the female population. And Tylenol very rarely helps manage a migraine. Oftentimes it takes a prescription that is not actually safe to take during pregnancy in order to manage a person's migraine. So then you talk about what are your alternatives. That's where specialists come in. So having those conversations early on in the prenatal care is where you start noticing, okay, these things may come up, and then this is how you tell the difference between your normal migraine and what might be a stroke, what might be that includes bleeding in the brain, or might be preeclampsia like we talked about earlier. We start talking about the other signs and symptoms, because again, headaches just in general are very common. I don't know how many patients with migraines that again are managed by a prescription that they can't take. All right, well, let's get to a specialist early on in your pregnancy, so we can say, okay, this medicine may not work as well as your medicine outside of pregnancy, but we know it's safe to take during pregnancy, and it can manage this same thing. And in that situation, if now you're on this medication that has been prescribed by the specialist and you've taken it, you still have a headache, you got a different problem. That's when we know that a disease is forming or that disease is worsening. When it comes to an insurance thing, depending on the person's insurance, is exactly right. But most of the time, you have insurance that's covered through maybe your job or something like that. Oftentimes, pregnancy is kind of covered in general. So you pay whatever you pay at the beginning, and then you talk about meeting your deductible. You're gonna meet it because I'm not a cheap date. So you're gonna hit your deductible quick if you're pregnant and seeing an OBGYN, really any healthcare provider. So that ends up, I try to encourage my patients to forget about that part anyway, because if you're worrying about your insurance and you have a problem that could take your life, you're worrying about kind of the wrong thing. I need you to come in and we can help you. We'll deal with the insurance thing later. And so that it tends not to be as big of an issue as far as what plan you're on or anything like that. Because yeah, there are a lot of times, if I got a problem, I might not go to the emergency room right away because I know that's going to cost me. Then I got to follow up with my primary care doctor, and that's going to cost me too. So that matters for things outside of pregnancy a lot more than things during pregnancy. They have that what's called the global fee for the majority of third-party payers like Blue Cross Blue Shield, United Healthcare, and things like that.
And so to dovetail back,
yes, sir.
Because in my brain, I'm really trying to understand how our numbers within our community are where they are.
Yeah.
And so then I'm also going to ask the question: do you presuppose that this concept of maybe not having prenatal consultations or things like that to talk about predisposition to, I don't know, other issues like migraines and whatnot, may be a contributor to other things down the line where I didn't know I couldn't take this prescribed.
Yeah.
You know what I'm saying? I'm just trying to understand,
Absolutely.
could these be factors
Yeah.
in what we're doing?
That's definitely one of many factors. Everybody in this room is Black. Almost. I don't know. Maybe?
No.
Okay.
Sorry.
Close enough. So we know though that in the Black population, we're not going to the doctor as often as we need to. For a lot of different reasons. We don't have a healthy trust in the healthcare system. And it's earned now. The healthcare system has earned that distrust, there's no doubt about it. But that gets passed on. I'm not going to grandma didn't go to the doctor because she went to the doctor once and something bad happened. I'm not going to that doctor anymore. I got patients right now who I'll see in the office on a regular basis, but they will refuse to go to the hospital that I work at. It's right next to my office. I'm not going there. That's where so and so died. I'm not going there because they've got this bad connection with it. Or I will wait until it's about to kill me before I go see it. You're gonna have to drag me to the doctor. That's kind of in our culture for, again, a lot of different reasons. And so that doesn't go away just because the person got pregnant. In fact, it may get worse. You have some people that say, do not go to the doctor until you feel a baby. And by then, you could have had a stroke. We could have prevented your blood pressure being a problem by putting you on the proper medication. We could have prevented the number of infections that you've had by just coming in much earlier. But that cultural piece is very big into why we see a lot of the problems. Because it's not just, yes, the system does not listen as well as it should. Absolutely. But we as a people don't also talk as much as we should. We need to speak up. We need to go in early. And there are a lot of reasons why it's not a possibility to go in early. We are uninsured a good portion of the time. because of the jobs that we have, they don't offer insurance. Now I got to sign up for state-sponsored insurance, but I've gotten one of these new jobs that gives me $15 an hour, and the state thinks that might be too much, so it's not going to cover it. So now I got to go and find the Affordable Care Act and try to navigate that system, which is nearly, I could be here the entire rest of the day trying to talk through that problem, but I definitely feel you on that. Yes, ma'am.
I have one question. I might have stepped out, but did you get the definition of preeclampsia?
I did not, and that's a great question. I was kind of waiting on it. So preeclampsia is a disease exclusive of pregnancy. It happens when a person has high blood pressure and has other symptoms or signs or factors going along with it. Primarily, you see things like protein in the urine. So whenever a person comes in for a prenatal visit, we always get a urine sample, we test it, see if there's any protein in it. We always check their blood pressure. Again, we see the blood pressure go up in the third trimester towards the end of the pregnancy, and that if you are prone to having high blood pressure outside of pregnancy, that's automatically going to put you at higher risk for developing preeclampsia during the pregnancy. And so we always put those two factors in. Then there are other things, because sometimes protein in the urine is not going to show up right away, but they come in with a headache. They come in with visual changes. They come in with swelling that's exceedingly abnormal. Or we check lab values, and those are abnormal, blood work, and that ends up being abnormal. And so preeclampsia, so the normal blood pressure, it keeps the American Heart Association keeps wanting to bring it down, which is appropriate for what's considered normal and when we should start thinking about treatment, especially for Black folks. But in general, a blood pressure under 140 over 90 for a pregnant person, we are not going to bother too much. Between 140 and 160, we're going to start talking. We maybe even have to consider delivery early. Between 90 and 100 on the bottom number, the diastolic number, we have to consider 110 actually. We have to consider intervening. Above 160 systolic for that top number, above 110 diastolic for that bottom number, we really got to talk about, regardless really of where they are in the pregnancy, really got to start having a conversation about, do we need to have this baby now, or can we wait a little bit in a safe way? Because again, high blood pressure, the standard number is around 12 to 13% of pregnancies will have a hypertensive disorder, will have a high blood pressure issue. The number right now is ridiculous high. I honestly cannot tell you the percentage because it's much higher than what the average is. Especially here in Indiana, because we have an obesity problem, we have a cigarette usage problem, we have an access to healthcare problem. We got a lot of issues. So that's what preeclampsia is. Pregnancy-related high blood pressure disorder. Outside of pregnancy, you can't have preeclampsia. We believe, one thing is, we cannot study things related to pregnancy ethically, because I can't say, I'm going to take this, I cannot ethically say, enforce that. I'm going to take this group of pregnant women and do this to you and see what happens to your baby and not do it to this group of pregnant women. Now that has been done, but that is unethical. So we can't study it as much as in depth as we'd like to, but we do know that the placenta being implanted is related to preeclampsia. Without a placenta, no preeclampsia. Does that make sense? I feel a question coming from Dr. Berry. You sure? Okay. Any other questions before we move on? All right. So delivery. Again, we're trying to get to the end of the pregnancy, and once we get there, these are some of the complications that are going to contribute to how the pregnancy ends up. So having when you're in labor, we are monitoring the baby. We sometimes will see an abnormal fetal heart rate tracing. So we like to see the heartbeat go up and down a little bit, and even go up in response to activity. If we ever see it flat or going down, that's a problem. Labor lasting for too long, how long that's supposed to be is kind of variable for the person and the baby. So if things are going well, we can let things go a little longer. If things are not going well, then we need to shorten it up. Infection and bleeding, again, two of the biggest reasons why we have a high maternal mortality rate in this country. And then also high blood pressure, like we just mentioned. And so just briefly, I want to talk about the indications for needing a C-section. So there's a lot of them, but any issue with these leads to this in a lot of cases. So if you're having, the baby's not looking good and we're concerned that the baby's not getting enough oxygen, we might say we need to end this pregnancy, not let you try to push because it's not safe, you're too far away from trying to push, and your baby's having complications. So we might need to do a C-section for that. If the labor has gone on for an extended period of time, that increases the chances of having an infection and hemorrhage and a high blood pressure, so we should consider a C-section at that time. Infection can impact the mom and the baby, as we know, so that may be another reason why we end up with a C-section. Sometimes the baby's just too big, y'all. It's just not gonna fit. You're this big and the baby's this big. It's just not gonna come out that way. Not everybody's meant to have a vaginal. So those are kind of some brief, very kind of surface level indications for needing a C-section. Sometimes this hemorrhage thing happens during the actual labor process. Sometimes it happens after, in the postpartum time frame. So postpartum starts once the baby is fully out of the mother, and that immediately starts our postpartum time frame. Hemorrhage, big problem. If you've been in labor for a long time, you have an infection for a long time, your uterus is not going to contract as well. The uterus is not going to contract as well and cause a bleeding issue. Again, high blood pressure, oftentimes we'll see the body start to regulate itself and go back to, or try to start going back to normal, whatever that really means, almost immediately after the baby comes out. But occasionally we won't see a high blood pressure issue until after the baby, within 24 to 72 hours after the baby is born. Mood disorders. It used to be called postpartum depression. We see it often in the postpartum time frame. More often than not, though, we start seeing signs and symptoms during the pregnancy. So we call it antenatal mood disorders, where we can see depression, anxiety, evidence of PTSD, all of that stuff during the pregnancy. And unfortunately, society has been lazy and just saying, oh, you're just pregnant. Oh, it'll be over after the baby gets here. And then we start seeing people having severe complications after the deliveries. And also infection. Again, in relation to the type of delivery the person has, how long they were in labor. So just some quick tips on how to have a healthy pregnancy. Preconception counseling, if at all possible, go see your doctor with your partner, if y'all can, if y'all are in that kind of relationship. Go see the doctor before pregnancy actually occurs. To have a healthy pregnancy, the best way is to enter a pregnancy healthy. I'll say that again. To have a healthy pregnancy, the best way is to enter a pregnancy already healthy. The healthier you are, the healthier the outcome. So getting advice on how to maintain health during pregnancy, before the pregnancy actually occurs, is very helpful. Early prenatal care. Get in as soon as you find out you're pregnant. Sometimes you call a doctor and they'll say, oh, we don't need to see you until this point in the pregnancy, but at least your foot is in the door and you have an appointment scheduled. Wait until later, or like I mentioned earlier, when that baby is felt, then maybe a little too late. And then consistent prenatal care. Getting in the door the first time is great, but keep coming back. You got to keep coming back so we can educate on what to expect at this point in the pregnancy and the next point, and then when it's time to come in and that kind of deal. And then healthy support from family, partners, friends. Prenatal vitamins are useful for the mother more than the baby. The pregnancy is going to steal from the mom, so the mother takes the prenatal vitamin to replenish what the baby is taking. Adequate hydration, as we mentioned earlier, and then proper education is very, 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 very important. If you've never had a child before, knowing what your body is about to go through, knowing what your partner's body is about to go through, can be useful for both you and her, and then also for the baby. And then breastfeeding classes, if breastfeeding is the way that you plan on feeding that child. And then healthy communication between each other and between your healthcare providers. Very, very important. All right? Any questions about that? That's all I got. Awesome. That's all. Now.